Brilliant. So good evening, everyone. Sorry for the technical difficulties to start us off. My name's Ashlea Hargreaves. I'm a senior hepatology liver transplant research physiotherapist working at the Queen Elizabeth Hospital in Birmingham. My current role is based on the ExaLT Trial. So the ExaLT Trial is a home-based exercise and motivational behaviour programme, both before and after liver transplantation. This is a large multi-centre trial between ourselves at the Queen Elizabeth Hospital and the Royal Free in London, looking at patient outcomes both before and after transplantation. Next slide, please, Izzy. Thank you. So the physiotherapy team at the QE consists of myself and Alice Freer, who's one of my peer research physiotherapists. And we've also got Sonia, who's one of our research physiotherapy assistant. And we're just a small drop in the ocean. We're a huge MDT as part of the trial, consisting of consultant hepatologists, anaesthetists. We've got clinical nurse specialists, research nurses, research fellows, clinical trials team, support staff. So this is a big project, and we're just a small part to play within that. Next slide, please, Izzy. Great. So the ExaLT trial is a 1.5 million NIHR funded grant, and this was generated from Professor Matthew Armstrong and Dr. Felicity Williams. So they proposed the ExaLT trial. So Dr. Armstrong is the chief investigator of the trial, and Felicity Williams is the principal investigator of the trial. So basically, the trial was designed because they both highlighted an issue that patients on the transplant waiting list are waiting months, if not years, for a transplant. And within this time, because of the large symptom burden of liver disease, quality of life was degraded. And unfortunately, many patients do pass away whilst waiting for transplant. So what can we do as physiotherapists, as clinicians, to improve quality of life and improve physical frailty and improve outcomes for patients on the transplant waiting list? And here we are at ExaLT. So the study opened in 2022 and is due to close in 2026. And participants can have up to 1 year's worth of prehabilitation and 6 months of rehabilitation afterwards. The primary outcome for the study is quality of life, and this is measured by the SF36, and this is measured at 6 months post-transplant. Next slide, please, Izzy. So in terms of exclusion and inclusion criteria, so patients that are unfortunately unable to join us on the ExaLT trial, if you're listed for super urgent transplant, that's not feasible. Again, multi-organ transplantation, so whether it be combined liver, kidney, heart transplant, live liver-related donor, which we don't do at Birmingham at the moment from a liver perspective, and if someone's gone for a regraft. And of course, risk assessment and safety is so imperative. So those with severe hepatic encephalopathy or oxygen-dependent syndrome, such as HPS, those patients are also excluded. And patients without liver failure, so those with liver cancer in the absence of cirrhosis, polycystic liver disease, and those rare metabolic and genetic conditions such as hemochromatosis, Wilson's disease, and Alagille syndrome. And all our patients have had to be over 18 years and outpatient at the time of recruitment. Next slide, please, Izzy. So in terms of numbers across both sites, so us at the QE, we have recruited 227 and at the Royal Free 42. So the original numbers that we needed to generate for the trial were 266. We've actually over-recruited slightly because of various factors which have been authorised by the BCTU. So our total number of participants across both sites is 269. Next slide, please, Izzy. So as I said, why physical frailty? Why do we need to improve this? So essentially, frailty can be defined as a state of disease, decreased physiological reserve and increased vulnerability to health stressors. And this encompasses psychological, physical and social aspects. So within the ExaLT trial, we're encompassing everything, but more so from a physical perspective. So we know because of liver disease and the big symptom burden that it possesses, lots of patients have reduction of muscle mass, reduction of strength, and reduction to participate in activities of daily living. We know from previous research that those with increased physical frailty have a higher increased waiting list mortality, a longer post-operative recovery with frequent complications, a reduction in quality of life, and of course, recruitment of further hospital admissions. Next slide, please, Izzy. So in terms of optimizing the patients prior to surgery, so there's been lots of studies shown in other surgeries such as GI, upper GI surgeries, in terms of optimizing patients before they hit that surgical procedure. So essentially what we want to do is optimize patients' physical frailty as high as we can. They're going to hit surgery, which is a large physiological and psychological stress on the body. So naturally the functional ability is going to dip off. Our premises, what we want to do is increase that functional capability so that dip off isn't as severe as it could be. Hopefully, the fitter that patients are going into surgery, the fitter and the quicker the recovery is going to be afterwards. And then looking at the graph below, so the blue line shows patients that have undergone prehabilitation and rehabilitation after surgery. So they optimize the physical function as best as possible, and then it's a quicker recovery back to baseline, and hopefully that continues to improve past the symptom burden after transplantation. Next slide, please, Izzy. So as I said, the primary aim of the study is to improve quality of life, and this is measured by the SF36 questionnaire. So in all participants, whether they're in the control arm or the intervention arm, they'll have a booklet of questionnaires to complete at every visit. And that comparison, as I said, will be at the physical element of the SF36. Next slide, please, Izzy. So it is a huge, huge trial. There's so much data that we've collected across the way. So we can also look at surgical complications, mental well-being and health, clinical markers of physical frailty, morbidity. We've also collected a lot of sleep data because we give patients activity watches. As patients come into the appointments, they'll have a full medical by one of our senior hepatology team. They'll have a full blood count, a full urine, ETG, ETS data set as well. And as I said, they'll do hand grips, they'll do functional tests, and we'll collect all that data at each visit. Next slide, please, Izzy. So as I said, to continue, what we want to look at from a more physical perspective is habitual physical activity levels. So looking at the activity watch, we can derive daily time spent in light, moderate and vigorous intensity physical activity. We can look at dose respondents for physical activity, so the frequency, intensity and duration of exercise that the individual participants complete. We're also looking at adherence to the home-based exercise programme. So this is where the behavioural element of the intervention arm comes into. So how can we get patients continuing their exercise past the trial and all the way throughout the trial? Also, perceptions of healthcare climate. So how supportive do we need to be as clinicians to empower those patients to continue their activity? And essentially self-determined motivation to exercise. So what are the barriers, what are the motivators that we can tap into with patients to get them to adhere to their exercise programme? Next slide, please, Izzy. So in terms of the trial timeline, so this is where it gets slightly complicated because as we went through recruitment, we had patients going through different visits at different time points. So essentially visit 1, which is 0 weeks, visit 2 is 6 weeks, and then visit 3 is a further 12 weeks after this. After visit 3, the time spent in between the visits goes to 12 weeks. And then the final visit from 5 to 6 is a 24-week time period. So this essentially shows that we want patients to continue their exercise and their motivational behaviour programme after we reduce that psychological support. Okay. The same with post-liver transplant. So visit 7 occurs at 6 weeks after transplant, visit 8, 12 weeks after transplant. And again, there's a bigger gap at visit 9, which hopefully will be the primary outcome. We've also recruited to a sub-study. So that's essentially mechanistic data looking at a 6-minute walk test, a CPET exercise bike, so essentially with the bike with the big mask on for those who are unsure of that, and a 6-minute walk test. So again, mechanistically, what is happening at a cellular level for these patients? And the number of patients we've recruited to this is 100, and this was only done at the QE site because of access to the CPET machine. So we've got 50 in the control arm and 50 in the intervention arm, so we'll have comparison data from a mechanistic point of view. The sub-study also entails ultrasound. So we've actually done ultrasound images of patients' lateral thighs. So again, looking at muscle from a cellular level and quality of muscle. As I said, at each visit, patients have a booklet of questionnaires that they complete, including the SF36 behavioural psychological questionnaires. They also complete a number of functional tests, such as the LFI and the DARSI. So the LFI being a liver frailty index, which consists of 3 hand grips, a balance test, and a sit-to-stand test to determine physical frailty. As I said, they get given a activity watch, which is posted out to them, and then they bring it back. We download the data from that. And then we'll also look at anthropometry. So looking at the triceps, the mid-arm circumference, and the mid-arm muscle mass. Next slide, please, Izzy. So in terms of intervention versus control, so we inputted patients at randomization into the computer from BCTU, and they essentially told us whether the patient would be intervention or control. Obviously, this isn't a blinded study, as us as clinicians deliver the intervention, and we needed to know whether they'd be intervention to access the motivational behaviour programme or control to just access a generic booklet. So as I said, patients have the OBS, the weight, the height at each visit. They have the anthros, LFI, and a full blood count, and questionnaires and activity watch. So all patients have the access to this. The difference with the intervention arm is that patients have a motivational education package. So before the trial started, every clinician that had patient interaction underwent motivational behaviour training at the University of Birmingham. And essentially, we were taught how to deliver motivational education. So within the education package, we look at motivators and barriers to adherence and to treatment. We look at VAS scales, so getting patients to have an awareness and a self-directed of the pain and their adherence. And again, providing that empowerment. The difference in terms of the intervention is that those in the intervention arm have a personalised exercise programme consisting of resistance and aerobic activity. So the resistance goes from levels 1 to 6, 1 being the easier programs, 6 being the harder. And again, likewise with the aerobic, level 10 being the most difficult level. We ask patients to pick 2 upper body exercises, 2 lower body exercises on 1 core to make up the resistance program, and likewise with the aerobic. Difference with the control arm versus the intervention. So for the intervention arm, patients actually had follow-up telehealth calls. So we called patients from their homes in between their face-to-face visits. So again, reinstalling that education, checking up on their exercise technique, if they had any concerns, any problems that they had to pick up. And again, that was completed at week 2 for 8, 10, 16 and 20. So as you can see, that support gradually dropped off as the trial continued as well. When patients had their transplant, they went into phase 2 of the trial, so the post-transplant arm. Now, we've got a dedicated team of physiotherapists on ITU anyway, so we as trial physiotherapists didn't get involved at that point. The ITU team saw those patients as standard of care. Once they were discharged back onto the surgical ward, that's when myself, Alice and Sonia went to see those patients. In the intervention arm, the patients had 2 lots of daily intervention from ourselves until they were independent. The control arm just had standard of care. So that might be if patients are up and mobile, it might be that we see them once every 2 days, once every 3 days, depending on patient caseload. Equally, in terms of post-transplant outpatients, they had a follow-up telehealth call at 4 weeks, 8 weeks and 16 weeks post-transplant again. Next slide, please, Izzy. And essentially, the control aspect of the trial, those patients had a generic exercise booklet. So they didn't get the motivational behaviour package, they didn't get the personalised exercise, they just got generic standard of care exercises. In terms of the intervention as well, the intervention arm got activity diaries and exercise booklets. The control arm didn't. Next slide, please, Izzy. So as I said, we're looking at mechanistic objectives as well. So looking at dose-dependent effect of home-based exercise on physical fitness and muscle biology. So as I said, we recruited 100 patients to this, 50 of the control arm, 50 of the intervention arm. And hopefully we can show that on a cellular level, the exercise and the adherence can help promote muscle growth and substance. Next slide, please, Izzy. So yeah, that's an example of the 6-minute walk test. So essentially getting patients to walk from 2 cones for 6 minutes as quickly as possible. And we completed this at the baseline visit at 6 weeks, which was the visit 2. For those that didn't get transplanted within the time period, they completed these tests again at visit 6, which was 48 weeks. Or if they were transplanted and dropped into the second phase of the trial, we completed these at visit 9, which was 24 weeks after transplant. Next slide, please, Izzy. And next one, please. So where do we stand at the moment? At present, we've got no one in the control arm awaiting transplant, and we've just got one more participant in the intervention arm awaiting transplant. If that person was to be transplanted within the time period, she has access to a year's worth of rehabilitation after that. If not, then her final visit, which is actually next week, would be the end of the phase 1 of the trial. So every participant on the trial would have occurred at V6. So that phase of the trial would be closed. Next slide, please, Izzy. In terms of phase 2, we've actually had 135 participants transplanted. 66 of those have been intervention and 7 of those are awaiting a visit 9, which is the primary endpoint. 69 of control have been transplanted. So fairly even numbers, give or take 3, which is pretty good, to be fair. And 2 of those are awaiting visit 9. Next slide, please, Izzy. And in terms of the sub-study, all V6 sub-studies have been completed and we're just awaiting 3 more interventions at V9, and that's going to be completed at the end of June. Next slide, please, Izzy. So this is some patient feedback that we've got verbally that I've wanted to include. So for myself, it's been a real privilege to be part of this trial. Obviously, we've had protected time. It has been busy. We originally started off as part-time physiotherapists, and that soon went to full-time because of the demands of the trial. We asked patients how they thought, how they felt about the trial. Obviously, we can't be biased in terms of giving them any incentive. We've got to be as impartial as possible. But a lot of patients have been forthcoming with what they've asked and what they've told us. So a lot of them have noticed some physiological benefits, some psychological benefits. A lot of patients said that they enjoyed the consistency of seeing the same clinicians, the same team. Doing the exercises made them feel calmer. So actually coming in for transplant, they were settled, they knew what to expect, they knew who they were going to see. And we've had some really good compliments to say that participants believe that this kind of programme should be compulsory for everyone on the transplant waiting list, and they do really feel passionate and beneficial that this can make such a big difference. Next slide, please, Izzy. And this was one of our lovely patients as well. So she was a keen runner. She was studying to be an occupational therapist before she became unwell. She previously did marathons, half marathons, and unfortunately was really debilitated by her symptoms. And utilising the trial, she was able to get up and get back to not just walking, but after transplant, we supported her in getting back running via the Couch to 5K. So a really good positive story from one of our participants there that was happy to share that. Next slide, please, Izzy. Yeah, that's just a little bit of feedback. And that's it. So that was just a bit of a whistle-stop tour. I'm more than happy to answer any questions that anyone's got.